Good morning, everyone. This is the session which is related to rehabilitation, and I would like to welcome Mr. Naveen Kumar to do his talk on recent advances in spinal cord injury rehabilitation. Mr. Naveen Kumar is a consultant in spinal cord injuries at the Midland Center for Spinal Injuries in Oswestry. He is also honorary consultant in spinal cord injuries in the University Hospitals, Birmingham, honorary senior lecturer, Keele University, honorary senior lecturer, Edge Hill University, past chair of Spinal Cord Injury Medicine Special Interest Group of BSPRM, which is the British Society of Rehab Medicine, and the current president of British Association of Spinal Cord Injury Specialists. The Midland Center for Spinal Injuries at the Robert Jones and Agnes Hunt Orthopedic Hospital, Oswestry, is an internationally recognized center for excellence for managing musculoskeletal disorders. And Mr. Kumar has an extensive expertise in assessment and management of patients who have spinal cord injuries. He was trained in spinal injuries in the UK and in Southport, Glasgow, and Stoke Mandeville, and went on to do fellowships in the United States of America. As a board-certified fellow, he is recognized as a trainer by the European Board of PRM. He has published several papers in peer-reviewed journals on different studies, including RCTs, outcome measures, epidemiology, natural history, and outcome of traumatic spinal cord injuries, and authored chapters on spinal injuries. He's the chair of the special interest group, and he also teaches at Keele University to the medical students, postgraduate students, and postgraduate trainees in rehab medicine from West Midlands Deanery. Welcome, Mr. Kumar.
Thank you for a kind introduction. I'll start off with a literature review which was carried out by Manan Shah in 2020, where they carried out extensive review of literature of 46 articles over 28 years on current advances in management of spinal cord injury. And they concluded that looking at all the literature, that still, despite recent advances, more trials on a larger scale and further research is still required to evidence the current advances in spinal cord injury management. Our patients, they do ask this question quite commonly at various stages of their management, from initial stage rehabilitation and then subsequent follow-up, which we provide as a holistic MDT review for the remaining years of their life. And so we do direct them to the ICORD website, particularly to this, the latest available guidance on experimental treatments for spinal cord injury. And we do know there are 4 different main categories of experimental treatments that are proposed, mainly based on the principles of neuroprotection, neuroplasticity, repair or regeneration, and replace or assist with function with engineering or electronic devices to try and improve independent activity and our mobility. We all know that through cascade of events at physiological level, once there's an injury, through release of various chemical mediators of inflammation, cytokines and prostaglandins and free radicals, there's a cascade of events which runs into leading on to lipid peroxidation and myelin and axon damage, ultimately leading on to permanent neurological deficit. So the neuroprotection is the medication method. Our trials were essentially based on these principles to try and minimize the injury and protect the neural tissue. Various drugs have been used or tried, but I would like to mention that riluzole, which is a sodium channel blocker, phase 1 trials have shown that there is a gain of 15 motor scores, but phase 2B and 3 trials are still ongoing. Minocycline, again, which we know is a doxycycline variant, phase 2 trials have shown improvement in motor scores by 14 points, and phase 3 trials are still ongoing. With regard to neuroregeneration, again, there are various medications or drugs which have been tried, but cetrin has proven some benefit in phase 1 and 2A trials, and improvements have also been seen in the Asia motor scores. Anti-NOGO study, which is a monoclonal antibody study, it's currently at this stage, it's still in the early phase clinical trials, and various centers in the UK are still a part of that study amongst the MSKI network group. Moving on to neuromodulation, stem cell treatment, and prosthetic treatment. Neuromodulation essentially based on the principles of stimulating the spinal cord and the brain stimulation. The main mechanism that's hoping to achieve is to improve neural connections and circuits within the spinal cord in the remaining intact tracts. The evidence on efficacy is some benefit of improved functional outcomes have been shown in some studies. With regard to cell-based therapies, although phase 1 trials have showed promising results, unfortunately phase 2 and phase 3 trials, they could not be carried out or completed due to, or unless the ethical and legal concerns are addressed. With regard to prosthetic devices, these are the devices which are used to provide physical assistance by restoring certain level of physical activity and improving cardiovascular health and gait parameters. Several studies have shown improvement in functional outcomes and restoring certain level of physical activity. So with regard to stem cell treatment, we know that someone who has suffered an injury such as this, the regeneration is not possible at this point of time. Work is still in progress on stem cells, olfactory and seething cells, and nerve grafts and nerve rerouting, which we'll probably hear from our next speaker, Simon Picard. But the options with regard to stem cell treatment, we need to know that at this stage, the work is still in progress. Some of you might have seen the BBC Panorama program a few years ago, which was based on the principles of the title as To Walk Again. And this was based on olfactory and sheathing cells carried out by the Polish team of neurosurgeons in partnership with the British researcher, Dr. Jeffrey Reisman, and also some of the researchers from Oswestry. This was a trial which was for a gentleman who had suffered a complete paraplegia following a stab wound, similar more or less like a hemisection of the cord, and received the treatment. And ambulation was achieved with stem cell treatment, with olfactory and sheathing cells, and also with intensive program of rehabilitation, about 5 hours of specialist physiotherapy every day. So being located in an elective orthopedic hospital in Oswestry, we do have access to various very relevant departments. Particularly with regard to the basic science and research, we do have access to Keele University basic scientists who are involved in carrying out extensive research at cellular levels, and we are able to perform or demonstrate or evidence in publication that the bone marrow stromal cells, they promote sensory nerve root growth or inhibitory substrates, and this does include the no-go-A. In addition, we also were able to establish that MSC serotonin-derived proteins, they can enhance nerve growth, and which was again published in the journals. With regard to technological options, there are various options available. So ranging from electrical stimulation, got magnetic stimulation, exoskeletons, robotics, interface technology in the form of brain-computer and then brain-machine interface, virtual reality, assisted communication technology, environmental controls, and 3D printing. And some of you might have heard from the previous speaker, Brian Kwan, about 3D printing the spinal cord model. And also from practical point of view, from some of our patients, they do come by printing the splints for their upper wrist or the ankles for positioning and maintaining. So it's custom made, and it's can be still applied for our patients. With regard to electrical stimulation, it's a technique of applying safe levels of electrical current to stimulate the various organs of the body. And a functional electrical stimulation, commonly known as FES, it can help to facilitate and improve limb movements and also other body functions. FES was initially designed to provide assistance with standing and walking, and subsequently there are different types of electrical stimulation depending on how you use the electrode. So there is a surface electrodes and there is percutaneous electrodes, again have the disadvantage of having prone to infections, and implanted systems. There are several systems, I can't go into all of them. These implanted systems are invasive, but a couple of them which I would like to mention are the freehand system and the SARSI. SARSI is essentially a sacral anterior root stimulation system. Freehand system was used, when I was in Southport, I used to see a consultant called Mr. Pradeep Seth who carried out about 20 cases a couple of decades ago. But essentially it is an implantation of a system, and there is ample evidence, level 4, and also from various publications to establish that this system does help in achieving a greater grip strength, grasping, improving activities of daily living and function, and hence overall independence. Phrenic nerve stimulation is a technique which is again used as an electrical stimulation to stimulate the phrenic nerve so that we can cause or achieve diaphragmatic contraction, and typically used for individuals who suffered C3 complete or above C3 levels, and this is to improve or relieve from ventilation devices. Although this has been developed several decades ago, still much work is still required in terms of innovation and advancement in this area. So essentially, phrenic nerve stimulation system has got, as you can see, a monopole electrode. There is a receiver, and there are external transmitter which is used. And surface marking on a patient, how to show where the positioning of the surgical incision is, an intraoperative picture which shows where the electrodes are attached onto the phrenic nerve. And similarly, the diaphragmatic pacing is another option, wherein the pacing is carried out on the intramuscular electrodes are placed on the diaphragm. And again, the advantages of the diaphragmatic pacing, similar to the phrenic pacing, is to reduce or eliminate the need for a ventilator or other breathing devices, and helps the patient to breathe and speak more naturally. And it's also, of course, helps with improving mobility and transportation, because they don't have to carry heavy ventilator and other devices. Psychological benefit, it facilitates easier dressing, breathing, and improved comfort, and more importantly, decrease the risk of respiratory infections, and hence the morbidity and or life expectancy for these groups of patients. So moving on to SARSI system, which was known traditionally in the UK as the Finetech Brindley system, and was rebranded as a WOCARE system in the US. Essentially, primary function of this was to try and achieve bladder function control after complete spinal cord injury. The secondary functional outcomes were to try and achieve control over bowel evacuation and also erection. And then electroejaculation is also used in our patients, where we have tried vibroejaculatory technique and it's failed, and then we would like to try and retrieve sperms for the purpose of artificial insemination or in vitro fertilization. We do resort to electroejaculation technique. Neuromodulation is also on the news now. You might have seen on 7th of February 2022, a paralyzed man walks with a severed spine thanks to the implant, walking with his daughter. And again, it's essentially an epidural stimulation. A 16 electrode epidural array is implanted onto the epidural space, and you do have an electronic system to try and facilitate ambulation. And this is a voluntary rhythmic activity. With training, we can achieve step-like movements and also independent standing. And the publication from Gill et al. In the Journal of Nature Medicine, 2018, with epidural stimulation and 43 weeks of dynamic task-specific training, they were able to achieve bilateral stepping on a treadmill without the need for a trainer or without the need for a body weight assisted support systems. And also they were able to achieve independent stepping over the ground while using a front wheel walker with a trainer and in the region of the hip to maintain some balance. FES exercises we know that there is ample evidence to show that it improves cardiovascular fitness. It decreases the risk also of the diabetes and osteoporosis. In addition to this, electrical stimulation, exercises, and weight bearing, it helps our patients to minimize the risk of pressure sores by improving tissue oxygen levels, increases the muscle bulk, and also alters the pressure distribution for these groups of patients. So hence minimizing the risk of pressure sores. There are different options of FES bikes. We've got stationary bikes, we've got mobile bikes, we've got FES rowing machines, and then electrical trainers. The range of options are available. So with regard to FMS, which is magnetic stimulation to produce useful body function, which can be varied depending on which location we resort to. Upper thoracic region, if this FMS is used, we can achieve inspiration and ventilation. If you're using in the lower thoracic region, you're aiming for achieving coughing, gastric emptying, and colonic transit. Lumbosacral region, if the FMS is placed, you're aiming to achieve micturition, defecation, colon transit, and also breaking down the spasms and other. Of course, the disadvantages are the larger size of the stimulator, higher power demand, and it's expensive. Exoskeleton, again, there's a range of options available. Commonly used ones are the Exo, Indigo, Rewalk, Rex, and Hall system. Amongst these five, Rex and Hall are quite commonly used in the UK. We know that this training of gait training using an exoskeleton helps our patients, and also they are quite useful in rehabilitation therapy, and exoskeleton robotic training also helps in central vascular health in terms of maintaining their cardiovascular health for our patients. So EXO is used for persons who got injury at C7 and below, and essentially users can initiate a step to shift the weight and step the initiation by pressing the button. It's a variable assist system. They can use it in real-time monitoring of the movements, and they are generated by the user. Rex is, again, a heavy machine. It's a 48 kilos. It is controlled by a joystick, and advantages for this is for manual wheelchairs. They can able to do transfers in and out. HAL system was designed by the Cyberdyne Japanese robotic company. There are two modes of function. One is it amplifies the wearer's motion. Second one is automatic motion support. Indigo is something which is used in the UK by several patients actually. It's suitable for individuals who got injury to C5 and below, and it's a slim profile. It's got no backpack. As a result, the weight is much less, and it's modular design. It's easy to on and off independently by our patients, and it can be controlled by even a smart app. Other one which is commonly used is a rewalk system, which again allows the user to perform self-initiated standing, walking, and stair navigation. So I've come across this child who suffered a complete paraplegia at the age of 8, and she has tried different exoskeleton options over the last few years. And she has tried free walk and also tried rewalk, and she's using regularly rewalk at the moment. Again, there are further options, and last week you might have seen on the BBC about the story of Harold, again, this is based on the principles of Kigo, which was designed by a Canadian company to increase the strength and endurance of the US soldiers. And most of these Kigo users, they can stand, they can walk longer, they can go up and down the stairs, they can kneel, they can even dance, and they can go back to work wearing that. Moving on to interface technology, again, this is a technology where essentially you're trying to amplify the prefrontal, premotor cortex signals to try. These EEG signals are amplified, and they're processed by a computer external device, and the control unit is sending signals to an implanted system. And this can vary from several channels, 16 channels and 32 channels, again, for different channel systems for upper limbs and lower limbs. And its integration of these is how it works. And again, virtual reality, again, also has got a role in terms of principles of neuromodulation, our neuroplasticity to try and facilitate achieving ambulation for lower limb paraplegics. For example, with a virtual reality, they have got a body weight support system or a treadmill, and then they're trying to achieve or learn how to walk on a treadmill. And then for an upper limb, E-systems are often used with a VR system for people who have got tetraplegia to improve upper limb function as well. Sometimes we resort to a combination of options rather than individual modalities, so we can integrate either FES, FMS, or brain-computer interface, or artificial intelligence, or VR to try and achieve a system which works in a hybrid model for our patients rather than just sticking to one individual option. An example of this would be, this is a young gentleman who was an accountant, was on his bike, and he was hit by a car and eventually suffered a polytrauma. As you can see, it's a 3-column unstable injury, complete transection of the cord, and complete paraplegia at T6 neurological level. In addition to T6 level complete paraplegia, he also suffered the crush injury to a leg, eventually compartment syndrome, etc. Cascade of events led to below-knee amputation, subsequently ended with above-knee amputation. So traditional treatment for a paraplegic patient with an amputation is just give him a pink foam or a prosthetic leg. So it's just to make it look good while if the person is sitting on a chair. But he was very determined. He wanted to stand and walk. With the foam prosthesis, you can't stand and walk. So the option has to be modular approach. What was done in this particular case was an above-knee prosthesis was purpose-built using a computer chip and a microprocessor which can talk to an exoskeleton, which is a Rex system. So you got a Rex system, and then you got an above-knee prosthesis system. Both were integrated as a hybrid model to try and achieve ambulation. So he uses it 3 days a week, and he's been using it for many years now. So it is a kind of, rather than just looking at a tip of an iceberg, we're looking at the whole, if possible, and try and looking at different combination of approach to achieve ambulation. So there are 12 centers in the country, and each center has got different approach. There are some variations in terms of service delivery or access to funding or access to technological options to try and provide the various treatment options or modalities that I mentioned here. But in essence, all spinal injury centers in the country, they provide acute care, restorative rehab, reintegration into community, and lifelong follow-up for our patients with spinal injuries in the UK. Like other centers, MCSI, which is where I work in Oswestry, it's essentially patient-centered, and it's a holistic, multidisciplinary team. So we work together collectively, aiming for our patient, keeping in the center, to try and achieve what we can. I would like to illustrate with this one case example. This is a story of Martin Aston, and he's known worldwide. He's won several British awards and international awards in mountain bike events, and unfortunately in one of the events he did suffer an injury resulting in a 3-column injury, fracture dislocation, T9-10, multiple non-contiguous spinal injuries. And he, in addition to polytrauma, he also suffered these from a spinal injury point of view. He was a T6 level, mid-thoracic, Asia impairment scale, A, complete paraplegia. So treatment options were offered by our spinal surgeons, and we took opinion and advice. And the patient decision was, I don't want surgery. I don't want to have a stiffness. That is his choice. Not for neurological recovery. All he preferred was a flexible, pain-free spine so that he can do what he can without any restrictions. That was his choice. So which we respected it, and that's him, and you can appreciate the extent of pain-free spine that he achieved. And he participated in the intensive program of structured rehabilitation in our center. He achieved independence with self-care, mobility, bladder, respiratory care, transfers, all aspects. Like if you go for a SCIM score, he was our highest achiever compared to our average patients, but I think every patients are different. And so he wanted to go back on mountain bike riding, which he returned to riding a bike soon after discharge. He evaluated exoskeleton as an option, and he tried the parawalker as well, as parawalker was designed or developed in Oswestry. And he walked half a mile, which is the twice the length of a corridor of our hospital. RJH main corridor is about a quarter mile, and then he did both the lengths by walking. So he's a complete paraplegic. So his personal preference is a parawalker rather than the exoskeleton. So again, options are provided. They are explored, different options, and we respect the patient choice and we support them. So it was his intention to return back to mountain bike riding, and this is a short video clip just to show that it says is returned back to riding a bike. And since 2013, he's been reviewed every year in Oswestry.
Are you looking for something? Are you searching for someone now?
No pain, no spasticity.
You say I feel better at midnight because the moon is your only friend. And I want you back home. I knew that you would wanna go without. I could be your hero if you want me to. You got to show me how. Like a rush of blood to the head. You were crushing.
Right, let's go. Go ahead. Go!
Like a rush of blood to the head. You were crushing hearts to the end. I'm a dreamer. I wanna be a better man. I'll never be all that you wanted. I'll give you everything that I can.
I would like to conclude by saying that there are, in addition to traditional methods of rehabilitation, we also resort to technological advances. And there are several advances taking place. They are being evolved, but with a holistic and interdisciplinary team approach and greater accessibility to technological options, for patients with spinal cord injuries, they can achieve greater level of independence and they can enjoy better quality of life. I would like to thank you all.
So thank you very much for a very detailed and rather inspiring talk on the advances in spinal cord injury rehabilitation. Can I throw this open to questions, please? Could you possibly introduce yourself and give your question?
Thank you. I'm Likith Alakandi. I'm a neurosurgeon working closely with this National Spinal Injuries Unit in Glasgow. Thank you, Naveen. That was a great overview. Particularly the last video was very inspiring and very heartening. I think these are things we work and live for. My question is from a surgical point of view. We talk about neuroprotection. What's the evidence you have in terms of the timing of surgery for decompression? Now, it is controversial. There are a lot of trials going on that discuss, etc. And I think it's a big part of innovation from a surgical aspect. Is it reasonable to compare the view we have on brain? When the brain is compressed acutely, you decompress it. Does it the same apply to another similar neural structure, i.e. the spinal cord? So what research is there in terms of neuroprotection, i.e. preventing secondary neural injury by early decompression, neuroplasty, etc.? So what's the direction we're taking at the moment for that? Thank you.
Yeah, I mean, Likith, I'm not a spinal or a neurosurgeon. I'm a consultant in spinal cord injury. And from a rehabilitation point of view, I cannot advise. All I can say from my point of view is with regard to surgery, recommending surgery, which we offer to our patient as an option, is only for those who have got persistent or progressive neurological deficit. With regard to timing of surgery, early or late, there are several researches which I have to defer to the literature, and it has varied, and some of them are proud to be, whether it's Taski's paper came up, and then Van Joost and others, they said, okay, there are statistical errors, and etc. And of course, as you know, and that we are collectively involved in the DISCUS project, which again is in the principles of trying to decompress, or laminoplasty or duroplasty method of trying to decompress and see whether a decompression can help in promoting neurological recovery. I do think there is a role for decompression, particularly when there is a patient who has got a significant neurological deficit and has got a progressive neurological deficit. There is no doubt that such patients should have had a surgical decompression. But what it is in my own personal experience or my view is that patients who are treated conservatively have seen a significant amount of recovery. But I cannot say, because sadly, to my knowledge, there is no research that's been carried out looking at non-operative method with operative method. I think until data is compared with a non-operative method and then early versus late, then only we'll know whether there is a significant evidence or a credible evidence to say that surgery is beneficial. And again, when compared to good non-surgical care, apologies, it has to be compared, because again, non-surgical management, there is a good and not so good treatment. So it has to be compared. So I know I haven't answered it properly, but I think it is still evidence is not clear. I think much research need to be done, well planned, to get a credible evidence.
Thank you very much. Just a question from my point of view. You alluded to some of the ethics issues that are going on that are making research quite difficult. Do you think that's something that's surmountable, or are we going to have to rely on areas that have less ethical problems to do this sort of research for us?
I think probably what you suggested, the later half seems to be a sensible option. But to my knowledge, practically it is difficult to convince a patient for having a treatment which is not proven to be safe and effective. I have personally come across about 8 patients who have received stem cell treatment in various parts of the UK. To my knowledge, I've not seen a single patient out of those 8 have recovered motor function. There are 2 out of the 8 who have told me that their sensory function has improved, means that their Asia A grade have tend to become Asia B. But again, sadly, their neuropathic pain has got worse. Although they have had some sensory improvement, they told me that neuropathic pain is worse. And then there are 3 patients who sadly developed cystic changes. Whether it is due to primary trauma or whether it is due to iatrogenic to the process of injections, these are all carried out outside the UK. They were not done in the UK because patient had access to funds, whether it is through private funding, personal funding, or whatever means. So they've spent about £40,000 or so in different parts of the world, and then I have not seen a single patient with stem cell treatment who have received a significant or any neurological recovery.
Thank you very much. And on behalf of the BritSpine committee, I'd like to give you this little token of our gratitude.
Thank you very much. Thank you, everyone. Thank you.